Good evening, everybody. On behalf of the Ceylon College of Physicians, you all are welcome to the fifth session of the Peer Learning Periphery to the Fore 2023 online case discussion by physicians working away from the center. My name is Dr. Rohita Amaravitarana, the moderator of the today event. We know that the physicians working in outstations with limited resources have evolved excellent clinical skills in patient management. So there is a lot to be learned from them. Peer learning periphery to the fore is a platform for the physicians who work away from the center to share their knowledge and experiences with us. In this session, two physicians present and discuss clinical cases in 1 hour period. Today, we have two consultants from DGH Matale and DGH Nuwarelia. At the end of both presentations, we will discuss the questions. Please send your questions to Q&A box. Let me to introduce the first speaker today, Dr. Eranga Thalagala, consultant gastroenterologist, DGH Matale. Dr. Eranga Thalagala, MBBS Peradeniya, MD Colombo. He is a higher clinical fellow in gastroenterology, IBD, and advanced endoscopy at Cambridge University Hospital, UK. He is going to talk on worsening of symptoms in a patients with ulcerative colitis. How to approach. Over to you, Dr. Ranga.
Thank you. Thank you. And first of all, I would like to thank CCP and Dr. Rohita for inviting me for this presentation. And so today I am going to speak about a worsening of symptoms in a patient with ulcerative colitis and how to approach. So this is a patient who I recently came, I treated. So first we'll go to the case history. Mr. A 62-year-old gentleman with ulcerative colitis presented with worsening of symptoms for 1 month duration. He was diagnosed to have ulcerative colitis in 2002. So this is almost now for 21 years. And in 2002, he was presented with blood and mucus diarrhea for 3 months duration. The initial endoscopy showed proctitis and histology confirmed the diagnosis of ulcerative proctitis. He was started on tailing off course of oral steroids and later he was started on sulfasalazine. During next 20 years, he has had several flares in 2004, 2006, at least 2 flares in 2007, 2009, 2017, 2019, and mind you, there were no records between 2009 and 2017, where patient recalls there were some more flares, including several hospital admissions for systemic steroids and for colonoscopy. The subsequent colonoscopy showed that his disease has evolved from ulcerative proctitis to left-sided colitis and then to pancolitis with time. All those colonoscopies and the histology reports have shown that he was having moderate to severe active colitis. All those acute flares had been treated with systemic steroids, and with that patient had achieved clinical remission and he was continued on sulfasalazine. After 2019, patient had not attended any clinics due to COVID-19 pandemic but had continued sulfasalazine. Now I would like to speak briefly about ulcerative colitis as an introduction. So we know that it is a diffuse non-specific inflammation of unknown origin that continuously damages the colonic mucosa from the rectal side, often leading to erosions and ulcers. And the exact pathophysiology is not known, but it is believed to be due to a dysregulated immune response to intraluminal microbiota and environmental factors in a genetically susceptible host. And it typically has a relapsing and remitting cause, and it can take a variable disease course. For an example, our patient initially only had proctitis, but now later it has evolved into a pancolitis. So we can classify the disease according to the extent and the severity. So this is a Montreal classification where we classify the disease as E1 if the patient is having proctitis only, E2 if it is left-sided colitis and disease is distal to the splenic fracture, and extensive colitis E3 where the disease is proximal to the splenic fracture. So our UC patients, about 30 to 60% of UC patients are having proctitis, and the symptoms are rectal bleeding, tenesmus, and urgency. About 16 to 45% of the patients is having left-sided or E2 disease, and their symptoms are proctitis plus diarrhea and abdominal cramping. The rest is about 15 to 35% of the patients are having extensive colitis. And in addition to the above mentioned symptoms, they have constitutional symptoms and fatigue and fever. So when we look at our patient, his disease has evolved and needed many courses of steroid, systemic steroid, but he was continuously being on sulfasalazine. Actually, that was our practice about 2 decades back. But during these 2 decades, the management of IBD and the UC has revolutionized, especially with the invent of the biologics and the new small molecule medicines. So now the treatment should be individualized, and it should be decided on the age, gender, disease location, severity, complications, and the presence or absence of extraintestinal manifestations. And the therapeutic approaches should be stratified by the disease severity. So basically, all the patients, each and every patient with ulcerative colitis, we just can't keep them on sulfasalazine or mesalazine. So we have to stratify the therapeutic approaches according to the severity. So this is a nice timeline showing the evolution of biologic therapy for IBD. So we have, when we discuss about the management of IBD, we have medical management options and surgical management options. So these are the currently available medical management options for UC. So we have sulfasalazine and the 5-ASAs such as mesalazine, and then we have immunomodulators such as azathioprine, 6-mercaptopurine. Then we have biologics and tofacitinib, and also we can use cyclosporin and tacrolimus for acute severe ulcerative colitis. So now when we encounter a patient with IBD, this is relevant for both UC and Crohn's disease, we should have goals. And the first goal is to achieve the symptomatic control, and then to have deep remission, and then to have the disease modification. So how we can do this? This is by tight monitoring. So what are the things we should monitor? So we have 3 targets. So first target is the to achieve clinical remission. The patient should be symptom free. Then we should our second target is to achieve a biochemical remission. That is the inflammatory marker, the CRP should be normalized, hemoglobin should be normalized, and also the decrease of calprotectin to a acceptable range. And the third target is the endoscopic remission, that is the endoscopic healing. So if these targets not achieved, we should step up our treatment, or we should intensify our treatment. So this is the new approach to any IBD patient. So again, to mention, if targets are not achieved, we should step up the treatment. If we diagnose that patient in 2023, our approach is totally different from unlike in 2000. So back to our patient again. This time this patient presented with worsening of symptoms over 1 month period. At presentation, he was having blood and mucus diarrhea about 10 times per day, and the blood was present on almost all occasions. And the consistency was semi-solid, and he was having nocturnal diarrhea, urgency, loss of appetite, loss of weight, and he's complaining of reduced energy levels. And also he was complaining of inflammatory type peripheral arthralgia. But importantly, there was no abdominal pain, no fever, and there were no recent history of hospital admissions, antibiotics, or NSAID exposure. Past medical history was notable for osteoarthritis and hypertension. For hypertension, he was on medication, and past surgical history, there was a PUH repair and no known allergies. And importantly, he's a non-smoker and consumes alcohol occasionally. He's a retired clerk. So examination revealed averagely built person, and he was pale and ill-looking, and he was not icteric, and there were no extra intestinal manifestations of IBD, and his heart rate was about 94 beats per minute. Blood pressure was normal. Importantly, abdomen was soft and non-tender. So his investigations, the full blood count revealed mild leukocytosis with normochromic normocytic anemia with high platelets, and his ESR and CRP was markedly high, more than 100. Creatinine was on the upper limit, normal, and the electrolytes were normal, albumin on the lower side. Stool full report showed presence of pus cells and RBCs, and the culture stool culture was negative for Salmonella and Shigella. So ideally, I should have done an urgent flexible sigmoidoscopy, but unfortunately, at the moment, I don't have a colonoscope, so I had to wait for 1 week and had to do this, get it done from the private sector. So this is after IV steroid, and it showed a moderate to severe pan colitis, and you can appreciate this is the cecum, and even the cecum is inflamed, and this is the TI, the terminal ileum. The terminal ileum was normal, and the histology revealed moderately active chronic pan colitis, most probably active UC, and luckily there were no dysplasia, especially when the patient was having very high ESR levels, and I was suspecting whether there's a possibility of a colorectal carcinoma, because this disease was going for 20 years, but luckily the endoscopy was negative for colorectal carcinoma, and the histology was also, there were no dysplasia. So diagnosis of acute severe UC was made. You commonly use this True Love and Wits criteria, which was published in 1955 to diagnose the disease activity of ulcerative colitis. If someone is having bloody stools more than 6 times per day with any of the other, if with any one of other parameters, we can diagnose acute severe UC. So this patient was having a pulse rate more than 90, and the hemoglobin was low, ESR and the CRP both were more than 30. So we made the diagnosis of acute severe ulcerative colitis. So the patient was admitted to the hospital and managed as acute severe UC with IV hydrocortisone 100 mg QDES for 5 days, and I have started oral metronidazole because I didn't have the facilities to evaluate for presence of C. diff toxin. So I gave empirically oral metronidazole, and because of high corticosteroid, I started on omeprazole, and then as bone protective measures, I have started calcium and vitamin D. So after 5 days of IV hydrocortisone, I have started the patient on 40 milligrams of oral prednisolone and tailed off 5 milligrams per week, and I have started on azathioprine because, of course, once patient has developed pan colitis, and when the patient presented with acute severe UC, very unlikely that patient will respond to a sulfasalazine or 5-ASA. So I have started azathioprine as a steroid sparing drug, and actually the azathioprine dose in IBD is 2 to 2.5 milligram per kg. But you can see here I have started on a very low dose. That is because ideally before starting azathioprine we should do the TPMT levels. Again, we can't do TPMT levels in our country. So if someone is having a TPMT deficiency, If you have started azathioprine in such a patient, it can cause bone toxicity leading to cytopenia. So what we can do in our setting is actually that is a dose dependent reaction. So we can start with a very low dose, then increase the dose gradually, and so after reviewing the patient with full blood count and liver function test. So that is the usual approach we take. So at the moment, patient is on 50 milligrams of azathioprine and about 10 milligrams of prednisolone per day. So ideally, I should have started a thromboprophylaxis in this patient. Unfortunately, with the limited resources we are having at the hospital, I couldn't start enoxaparin. So actually, we should start each and every patient admitted with acute severe UC flare. We should start with low dose heparin or enoxaparin. So my main intention is to discuss the management of acute severe UC. Acute severe UC is a life-threatening medical emergency with a considerable morbidity, which carries about morbidity around 30 to 40%. And patients with acute severe UC require hospital admission from prompt medical treatment, and colectomy is considered if medical therapy fails. Corticosteroid remains the primary initial therapy, although 1/3 of the patients do not respond to treatment. And for those 1/3 of the patients, we can consider cyclosporine, infliximab, and tacrolimus as rescue therapy. The timely decision making with rescue therapy or surgical treatment is critical to manage acute severe UC without compromising the health or safety of the patient. In addition, risk stratification and the use of predictive clinical parameters have improved the clinical outcome, and the most commonly used predictive clinical parameter is the Travis criteria. I will explain it later. In the active stage, it is critical to diagnose the general condition of the patient with the acute severe UC accurately and determine the extent of the disease, and they proceed with the treatment based on the treatment recommendation by the guidelines. When we treat the patients with acute severe UC, the surgery should always be considered as a treatment option, and the medical treatment should be carried out in close communication with the surgeon. So actually, we should involve the surgeon early in the management. So management of the day one is very critical, and we should do the following investigation. So we should perform blood in full blood count, serum urea and creatinine, electrolytes, ideally including magnesium, CRP, ESR, and lipid profile. So here we are interested in total cholesterol, because if we are going for IV cyclosporine as a rescue therapy, if the patient is having low cholesterol, that particular patient has a high risk for CNS toxicity. That's why we do the lipid profile at the acute stage in the day one. So we should do abdominal X-rays to look for dilatation, and if the patient is having very high fevers, we might have to do abdominal CT as well to detect the possibility of microperforations. So we should do stool studies. We should look for infectious pathogens such as C. diff, because the accompanying C. diff infection can carry a high risk for colectomy and mortality. And if we diagnose C. diff, ideally we should treat with vancomycin, or at least in our setting we can use oral metronidazole. And ideally we should do an urgent sigmoidoscopy. This is usually a unprepared sigmoidoscopy. We don't need to do the bowel preparation. This is just to assess the disease activity of the patient, and also to biopsy to rule out cytomegalovirus, because if the CMV is present, we need to treat CMV. So IV high dose steroid should be started. So usually we should give IV hydrocortisone 100 milligrams 6 hourly, and we should correct the dehydration and correct the electrolyte imbalances. And importantly, we should stop any medications that can precipitate colonic dilatation, so which includes opiates, NSAIDs, and anticholinergic, and importantly antidiarrheal. Although the patient is having diarrhea, we should not give antidiarrhea if we are suspecting acute severe UC. And the routine use of intravenous antibiotics in patients with uncomplicated acute severe UC is not recommended. But it may be appropriate when incipient colonic perforation, toxic dilatation, or infection is suspected. And as I mentioned earlier, the thromboprophylaxis should be given in ideal circumstances. So management at the day 2 and day 3, we should do a daily symptom assessment. So we should pay our attention to frequency and urgency of stools, rectal bleeding, increased pain or tenderness, which is a marker of instability. And we should monitor inflammatory markers such as CRP to determine the response to treatment. And we may have to perform interval abdominal x-rays if indicated by symptoms such as increased abdominal distension, marked decrease of cessation of bowel movement. So for an example, if someone presenting with bowel frequency of 15 to 16 times, suddenly on the day 2, if the only bowel opening once, so no bowel opening at all, then we should think about bowel perforation, and we should keep a very low threshold to repeat the abdominal x-rays. So after day 1, we should continue IV steroids and evaluate the daily symptoms. So after about 3 days, we should assess the patient whether the patient is responding to the steroid. So as I mentioned earlier, we use the Travis criteria or the Oxford criteria. So what does it mean? So it means after 3 days of IV corticosteroid, if someone is having a stool frequency of more than 8 times per day, or the stool frequency is between 3 to 7 times, plus CRP of more than 45%, have an 85% of likelihood of undergoing colectomy during that particular admission. So if someone is fulfilled this Travis criteria, that means as a steroid non-responder, then we should think about medical rescue therapy. The same thing. But when we consider medical rescue therapy, we should think whether the patient need surgery straight away. So these are the indications for the urgent indications for surgery without trying rescue therapy. So if the patient is having toxic dilatation with impending perforation, or if there's already interstitial perforation had been happened, or if there is a massive hemorrhage, or if there's a long-standing colitis intractability, we may have to consider a surgery or the colectomy directly. If a patient responds to IV steroid, it should be continued at least for 5 days, and then we should switch to oral prednisolone. In addition, we should have a plan to start a steroid-sparing drug such as azathioprine. So about 1/3 of the patients do not respond to IV steroid. So for those kind of patients, we can use infliximab, cyclosporine, or tacrolimus. But this tacrolimus is not included in the most of the European guidelines yet. So cyclosporine was the primary treatment for acute severe UC in the past. So nowadays we tend to use low dose cyclosporine, and that if we are using cyclosporine, we should measure the drug levels, and the concentration should be between 150 to 250, and serious infections had been reported in about 5% of the patients. And the major side effects of cyclosporines include nephrotoxicity, seizures, and anaphylaxis. And actually nowadays we prefer infliximab because of its more favorable side effect profile and their availability and good response rates. So tacrolimus is we can also use tacrolimus. The good thing about tacrolimus is we can use oral form at the initial stage because of its good bioavailability. Again, if we are going to use tacrolimus, we have to monitor the drug levels, which is a bit difficult at the moment. So if someone is not responding to infliximab, we can try infliximab dose intensification. So usually we give 5 milligram per kg in week 0, 2 and 6. If someone is not responding adequately to infliximab, we can give 1 to 2 additional infusions within the first 3 weeks, or when we give the second dose, we can give an increased dose, that is 10 milligram per kg. So this is a summary slide of the management of acute severe UC. So back to our patient. So I have started azathioprine in this patient. Is this the best choice? Actually, I am not 100% satisfied about my choice, because the current available resources made me to select azathioprine, because he is 62 years of age, and 60 years, more than 60. So when we start azathioprine in an elderly person, there's a high risk of lymphoma. So in an and also this is very long standing disease and had a recent acute severe UC, and he's having pancolitis. So my gut feeling is I might have to step up the treatment to a biologic in the near future. So in an ideal setting, my first choice would have been, after IV steroid, I would have, and the oral steroid course, I would have started either vedolizumab or ustekinumab, but unfortunately at the moment those are not widely available in our country. So this is the safety pyramid of IBD medications. The ustekinumab and the vedolizumab are the most safest drugs at the moment, and the steroid and the thiopurines plus anti-TNF combo treatment is the have more worse side effect profile. So thank you, and I think if there are any questions, I would answer those at the end of the session.
Thank you very much, Dr. Eranga, for very interesting and very informative presentation. We will discuss questions at the end of the next presentation. Next speaker is Dr. Ranga Gunasekara, Consultant General Physician in Fore. Ranga Gunasekara, MBBS Rupuna, MD Colombo. Overseas training at Norfolk and A&D and Norwich University Hospital, East UK. He has 6 publications in national and international journals. He is going to present on a rare case of young hypertension. Over to you, Dr. Ranga.
Thank you very much for the kind introduction, Dr. Rohit Amravitana, and I thank College of Physicians for giving me opportunity to present this case. Let me start with, it's a rare case of young hypertension. My patient is a 33-year-old young man from Australia. He presented to me with a continuous headache for 1 month duration, associated with dizziness and unsteady for the same duration. Headache was throbbing in nature and sometimes associated with nausea and vomiting. There was nocturnal headache, and headache increased with coughing and sneezing, and there was no associated seizures or loss of consciousness, no blurring of vision or diplopia. There was no associated aura or photophobia, no fever or associated constitutional symptoms, no episodic palpitations, chest pain, or anxiety. There were no associated constitutional symptoms, night sweats, or respiratory symptoms, no associated diarrhea, skin rashes, or episodes of sweating. Here the thing is getting interesting because in his past medical history in 2007, he was apparently investigated for young hypertension and diagnosed to have bilateral pheochromocytoma in a teaching hospital. He underwent right-sided pheochromocytoma excision in 2007, but unfortunately the records were not available to decide whether there was cortical sparing or not during the surgery. The record shows VMA was pre-op of 42 and the post-op of 13.8. Histology showed adrenal pheochromocytoma with unfavorable histology features. In the following year, in 2008, he underwent left pheochromocytoma excision and the tumor was excised and nodule identified. And post-operatively, he was on oral hydrocortisone. That was back in 2008. And then at the same teaching hospital, he had the following imaging in 2010 and 2011 respectively. 2010, there was a right suprarenal mass, left side gland was not visualized. In 2011, there was a right suprarenal mass, but the VMA was insignificant. And as well as in 2011, and patient's blood pressure, record shows patient's blood pressure was normalized without antihypertensives. And since then, in 2011 up to now, there were no records and there was no follow-up for the patient. Family history, basically unremarkable. There was no genetic diseases. He has 4 female siblings, and currently they are not being treated for any other illnesses. On examination, he was alert and oriented, and GCS was 15/15, and he was plethoric. Respiratory system examination was normal. Cardiovascular system examination shows pulse rate was 80 beats per minute, regular. There was no radial or radiofemoral delay, no carotid or vertebral bruise. Blood pressure shows it was 170/100 at the presentation in both arms. There was no cardiac murmur. Neurological exam, of course, pupils were equally reactive and 3 millimeters. There were nystagmus in lateral gaze and positive cerebellar signs, but there was no motor or sensory deficit. Fundoscopy did not reveal any signs of papilledema or any other abnormality. And the cranial nerves were intact as well. There was no skin rashes or dermatitis or feature suggestive vasculitis. At this point, we had 3 main differentials. We were thinking of whether it could be a recurrence of pheochromocytoma, or considering the fact that he has a sinister headache and neurological symptoms, whether it is a primary CNS tumor or some other malignancy with the paraneoplastic cerebellar syndromes, considering the cerebellar signs that he had. Investigation revealed he had a full blood count hemoglobin of 17, WBC of 7, platelet of 304. Creatinines were normal, electrolytes were normal, that is sodium and potassium, as well as calcium. Fasting blood sugar was 90, ESR was 55, and CRP was negative. UFR did not show any active sediments, and chest X-ray was a normal study as well. We performed a 2D echocardiogram. It did not show any abnormality other than the mild concentric LVH with ejection fraction of 60. So the initial management, our goal was to bring down the blood pressure. That was, then we started on amlodipine as well as the prazosin to control the blood pressure. We tried our best to avoid beta blockers because that could aggravate the pheochromocytoma if it is the case. And plan for this next step of investigations, because the patient has sinister headache and features of cerebellar involvement. We went ahead with the CECT brain initially, and it showed this sort of lesion. So this is the posterior cerebellar lesion. Then we went ahead with the ultrasound scan abdomen, and it shows bilateral renal masses. Straight away, because of the bilateral renal masses were there, we went ahead with the contrast enhanced CT abdomen. So it showed bilateral renal cell carcinomas, as well as there was a pancreatic tumor as well. So the CT abdomen shows the bilateral renal cell carcinoma, no pancreatic enhanced lesion, which the radiologist thought more likely to be a neuroendocrine tumor. And there was a right adrenal pheochromocytoma as well as there were lymph nodes which are likely to be metastasis from the pancreatic neuroendocrine tumor. So we knew that given the fact that bilateral renal cell carcinomas, pheochromocytoma plus neuroendocrine tumor, and there was a cerebellar hemangioblastoma, so we had to call upon an MDT, and including our team, and we got to know the hepatobiliary surgeon from TH Peradeniya, as well as the neurosurgeon from Kandy. So the rest of the team were from DG Stuvarelia, physician, endocrinologist, urological surgeon, radiologist, anesthetist, and oncologist. So MDT decision was to evaluate the patient biochemically evaluation, and then to do the MRI brain and the whole spine. And then after a discussion, we decide the neurosurgical intervention would be the first, and then family restraining, eye referral, as well as the abdominal surgery. So eye referral to see any eye lesions as retinoids. So this is the CT MRI brain and a section of the whole spine. MRI brain shows the hemangioblastoma clearly here. Whole spine did not reveal any lesion. So there was a right cerebellar hemangioblastoma with brainstem compression, but the spine was normal. We did the contrast CT chest as well. It was a normal study. And as per the MDT decision, we did the serum chromogranin A because we want to find out whether it's a pancreatic neuroendocrine tumor. As expected, it was high. However, urinary metanephrines were 0.24. That's not significant. So with the biochemical investigations and the imaging, we went ahead with another MDT, and there we transferred the patient to TH Kandy for neurosurgery. Patient underwent neurosurgery in January, and patient had a good recovery after that. Then the patient was referred to TH Peradeniya hepatobiliary team, as well as the urologist. Their patient underwent right adrenalectomy as well as right partial nephrectomy. And the microwave ablation of left renal CA was done. And because of the pancreatic neuroendocrine tumor, patient underwent the pyloric preserving pancreaticoduodenectomy or the Whipple surgery. Right. And remarkably, after many surgeries, subsequent surgeries, patient recovered very well. Now the patient is currently carrying out his activity of daily living without any impedance. Currently, patient is on hydrocortisone 10/5/5, and amlodipine is continued, and blood pressure is actually currently normalized, and now currently is not on any antihypertensives. This is the tumor resections, and this is actually the radiofrequency ablation of the the renal cell carcinoma, and this is during the surgery actually. So when let me discuss about the case. Actually, this was diagnosed to have von Lippmann-Lindau syndrome. Von Lippmann-Lindau syndrome is an inherited autosomal dominant disease manifested by a variety of benign and malignant tumors. Initial manifestation of the disease can occur in childhood, adolescence, or adulthood, with a mean age of initial presentation of approximately 26 years. So they can have hemangioblastomas of the brain and spine, retinal capillary hemangioblastomas or retinal angiomas, clear cell renal cell carcinomas, pheochromocytomas, endolymphatic sac tumors or the middle layer, serous cystadenomas or neuroendocrine tumors of the pancreas, and papillary cystadenomas or epidermis in the broad ligament. So families with VHL disease have been divided into type 1 and type 2 depending on their distribution, likelihood to develop in pheochromocytoma. The goal of improving survival and quality of life in patients with VHL disease has been aided by a better understanding of the natural history of the VHL-associated tumors. Morbidity and mortality in patients in VHL disease have decreased subsequently due to an improved understanding of the natural history and surgical techniques and the surveillance. So the key to management of these VHL patients is the surveillance and identify the lesions early and to deal with them. So renal cell carcinomas are mainly clear cell tumors. Although the diagnosis of RCC is rare in VHL disease prior to the age of 20, they are teenage cases of renal cell carcinoma. So thus screening is now recommended to begin at the age of 50 if there's a familial case. Hemangioblastomas are well circumscribed capillary-rich benign neoplasms in the brain and the spinal cord. They do not invade locally or metastases. So as I mentioned earlier, surveillance and risk of progression is the key to management of these patients. As I said, retinal hemangiomas also possible in this category, and the pheochromocytomas. Pheochromocytomas are seen in both sporadic and association with the genetic syndromes, including VHL disease, multiple endocrine neoplasia type 2, or pathogenic pericardial succinate, and pancreatic tumors, pancreatic cyst can be there, cystadenomas can be there, and neuroendocrine neoplasms can be there. So as I mentioned earlier, so these patients needs to be followed up for the recurrence of tumor, and there should be periodic assessment, and these sort of patients need multidisciplinary treatment approach always for the management. I highly acknowledge the support and the great contribution given in management of this patient by Dr. Buddhidip Dasanayaka, consultant hepatobiliary surgeon TH Peradeniya, and Dr. Sonali Gunatilaka, consultant endocrinologist DJS Nurelia, and Dr. Chula Kanishka, consultant neurosurgeon, National Hospital Kandy. Thank you.
Thank you very much, Dr. Ranga, for very interesting and very, very rare case presentation, and we learned a lot, and it's very informative presentation. So now we are coming to the Q&A session, and there are a couple of questions in Q&A box. May I ask first question from Dr. Eranga, yeah, will giving heparin to a patient of ultrasound ulcerative colitis, is there risk of bleeding?
No, not at all. And actually, they should be given prophylaxis.
Yeah. And one more questions again go to Dr. Ranga. Does sigmoidoscopy in the hyperacute stage carry out a risk of perforation?
Very good question. And actually, during that acute stage, we are interested only in to assess the disease activity and to look whether the patient is having CME infection or not. So we don't need to assess the extent of the disease. So we usually goes only to rectum or at best to the distal sigmoid colon. When we encounter a deep ulcer, we usually don't go beyond that. So, and also if sometimes some centers we have carbon dioxide as the a mode of inflation. So if carbon dioxide available and we use those, so by adhering to those things we can minimize the perforation risk. Yes, it carries a perforation risk, but we are doing just a very limited examination.
Okay. Thank you, Dr. Ranga. And also, again, this question also go to Dr. Ranga. Is one of the experience of one of a doctor, and he's telling, I have seen couple of patients worsening CRP were not, that means the symptoms are worsening and the 10 times bowel opening, but CRP is normal. His question is it possible?
So the thing is, if we suspect a UC flare, we don't rely on a single parameter. So it is a holistic approach. So we depends on the clinical parameters and biochemical parameters. And so is the one thing is, so presence of blood usually indicates a organic pathology, but mucus could be present even in IBS. But with a very high bowel opening frequency, sometimes due to friction or fissures, sometimes they might we might see blood, but that doesn't necessarily means that patient might be having UC flare. And actually, about 1/3 of our general population is having IBS. So, so about 30% of the IBD patients also having IBS. So, when a patient present, when a UC patient present with worsening of symptoms, we should think about those functional diseases as well. But the my answer to this would be it is a holistic approach. We should not rely on one single parameter.
Thank you very much, Dr. Ranga. And also, may I ask a question from Dr. Ranga? And your patient's surgery was done on, I think, January. And is there any relapses up to date for that patient, Dr. Ranga?
No, Dr. Rohita, actually, patient is doing very well. Actually, about a couple of days back also, I met him because we are regularly monitoring his situation and uptitrating the medication. Because probably because of his young, and we were able to identify the tumors just in case, because there was no capsular breach or the distant metastasis of any of the renal carcinomas, but there were some concerns about the metastasis of neuroendocrine tumor. But but we need to actually see next year after. So we need to find, we need to do the imaging to see whether there's any relapses. So far, he's doing very well.
Thank you very much, Dr. Ranga. It's very interesting, both cases, and very informative. So because of the time restrictions, and let me to wind up the sessions now. First, I would like to thanks two speakers today, Dr. Ranga Eranga Thalagala and Dr.Ranga Gunasekara for accepting our invitation to share their experiences. Also, I would like to thank CCP staff, audiovisual team, Mr. Nalina, and sponsor Merck Pharmaceutical for their continuous support, and all virtual participants who joined with us today. Thank you.